I'm now going to pass it over to Sandy Aubuchon, Clinical Director, Dr. Brown's Medical Division, to introduce today's speaker.
Thanks, Steve. Hello. Thank you for joining Dr. Brown's Medical for our first of many educational series provided by Handi-Craft Company, who are the makers of Dr. Brown's products. I'm honored to introduce our speaker, Louisa Ferrara. Louisa is a master prepared speech and language pathologist. She's worked as a pediatric specialist in feeding and swallowing disorders for the last 3 years at Winthrop University Hospital in Mineola, New York. She has her Master's of Science degree from Adelphi University and will be completing her PhD in December of this year. Congratulations, Louisa. Louisa has applied for board recognition in swallowing and swallowing disorders through the American Speech and Language Association. Her research interests include the pharyngeal swallowing mechanism in term and preterm infants, taste and smell development, and the developmental feeding milestones in children. Louisa has served as an adjunct professor at 2 universities in the New York area and has delivered numerous invited lectures on feeding, readiness in preterm infants, dysphagia management, and children with food aversions to physicians, nurses, and developmental specialists. Presenting Louisa Ferrara in her presentation, Apneas, Bradycardias, and Desaturations during oral feedings in Growing Preemies, Nature versus Nurture. Thanks, Louisa.
Hi, everyone. Thank you so much for joining us today. Thank you so much for having me, Sandy at Dr. Brown's, the whole sponsors. That's excellent. I also wanted to give out a special thanks to Dr. Renu Agarwal, who helped put some of these topics together, because as we all know, this is a really hot topic in a lot of the NICUs where we're working. So again, I'm very excited to speak with you today. So what are we going to speak about? We are going to look at the significance of laryngeal chemoreceptors. And this is somewhat of an untapped territory to a lot of us speech and feeding therapists in the NICUs, as well as to a lot of the nursing staffs and the NEOs. So we're going to break down the talk today. First, we're going to touch on some anatomy and physiology and neurology of A's, B's, and D's, as well as looking into the physiology of swallowing. And we're going to do that by looking at some video fluoroscopies, which is really my bread and butter. I love the X-ray testing to diagnose and look at the swallows. It just gives us so much important clinical information. So I'm going to show you some of those. And then we're going to talk about, of course, the management. You know, once we take a look at why some of these things might be happening, what can we do? How can we prevent it? And why is it so important that we do make this a priority in our NICUs? So, of course, the AAP in 1998 lets us know that we cannot send home a baby until they become a competent oral feeder. And that means that they have to exclusively be oral fed. Of course, we always try to eliminate the use of NGs or gastric tubes unless we absolutely have to. And we need them to have that good coordination of sucking, swallowing, and breathing, which of course means that they shouldn't have any A's, B's, or D's during or after feeds. Now, I don't know about your university, and I'm sure there's wide variation, but in our university, we have a 5-day Brady count. So let's say a child is having some Brady's. We do diagnose them with having maybe some incoordination of sucking, swallowing, and breathing, perhaps leading to some swallowing dysfunction. And you know, we can't send them home until they're Brady free for 5 days. And it's comical. I think some of them have this little calendar that they look at, and sure enough, on day 4 or 5, they'll have another Brady. And this is important. This is very important. It's a problem because from an administrative standpoint, we don't want to keep these babies in the hospital longer. Because of these repeated Brady's, sometimes the kids can stay in our NICU up to 45 days longer. So from an administrative standpoint, that is problematic. Obviously, from a clinical standpoint, we don't want them to have these incompetencies. And from a compassionate standpoint, these poor families, you know, they get ready to have their baby home, they get all excited, the room is ready, and then the kid Brady's on that day, right before they're about to come home, and then they have to start the process all over again. So this is a really important issue for, you know, all these various reasons. So taking a look at the nature versus nurture, why some of these A's, B's, and D's during feedings might be occurring. Obviously, they are not supposed to be here yet. Our preterm infants have known neural immaturity. They're primary reflexive, they have poor physiologic and state regulation, and they have this major incoordination of sucking, swallowing, and breathing. All right. What we know from a developmental standpoint is that the suck doesn't really become refined in utero until about 33 weeks gestational age. The swallow doesn't become refined until about 32 weeks. And that didactic suck swallow motion doesn't really become set until 34, 35 weeks gestational age. So when we start doing some oral nippling with these little ones, we really want to take that knowledge into consideration and not only go by their cues, but just go also by what we know, what they are supposed to be doing and what their neural capabilities are. When we look into sucking, swallowing, and breathing, research tells us that that doesn't become a very well established skill until roughly around 39 weeks post-menstrual age. So again, we're asking our little ones to do things that neurologically they may not be ready for. All right, when we look at some of our ideas of nurture, it really falls down to our feeding practices. What are the protocols for feeding in your NICUs? Do you go by gestational age only? Are you going by cues? Are you very volume driven? Are you very infant driven? You're going to hear me talk about that infant versus volume driven environment a little bit later on. And that alone really could be and should be its own talk. It is such a prevalent topic and idea and theology in the literature of late. So we're going to see more and more NICUs change to a more infant-driven culture, which is very exciting. Other things that we do are nipple flow rates that we use, different feeding positions that we use, and the use of encouragement during feeding. So we're going to touch on some of these as we go through. So before we get to anything, let's just look at some of the anatomy that's pertinent to our little ones. Here is a schematic from Goldfield and Smith, and you can see here this is a video fluoroscopy, and you can see the nipple in the infant's mouth. Here is where the nose would be, and that black line, this tubing, that's a nasogastric tube that's in place. This dot on the chin represents the jawline. And you can see everything in black is a liquid. So this nipple is filled with the liquid, which is a barium. It's a contrast material. And you see a little bit here in the mouth. And then this is where the tongue traces the palate. And here is some material down in the pharynx. So just looking over again, we have the nose, the nipple, the jaw. This is the nasogastric tube. And we're going to now take a closer look into this area. This is where really most of what we're going to be talking about tonight happens. Today, in the middle of the day, excuse me. So what do we have? Again, this is the tongue. We have, if you follow down the base of the tongue here, we have then the epiglottis in orange. This is responsible for opening and closing our airway. In blue, we have the velum, or the soft palate, which is responsible for closing out the nasal passage, which is here. In purple, we have the cricopharyngeus, or the upper esophageal sphincter, or for short, the UES. We always like a lot of terms, apparently. And this is responsible for opening and shutting the esophagus, which lies just below it. And when we talk about the airway, we're talking primarily about this area here. The most superior surface of the airway is the epiglottis. The most inferior surface of the larynx is the vocal folds, which are right here. Very important for this talk here in this area, the blue striped, this is our laryngeal vestibule, and this is considered part of our airway. All right, we are going to talk about how, A, we do not want liquid entering this area, but what happens when liquid does enter this area. Other things to note here, we have in the green polka dots, we have the vallecula. This is a pocket that liquid is allowed to pool in for like a semisecond. We want it to pool here very briefly and then fall out and go down into the esophagus. In our red polka dots here, the piriform sinus, we do not want material pooling there. And as you can see, it's close proximity to the airway. When material pools here, it could very easily pour into the airway. So this is something we don't like. When talking about, excuse me. Oh, okay. Now let's take a quick look at what the bolus is supposed to do. So again, it's supposed to go down the base of the tongue, pool for a semisecond in the vallecula, and then move down through the esophagus. All right, again, we want the material to come down over the base of the tongue, pool for a semisecond in the vallecula, go through the cricopharyngeus, and down into the esophagus. Note, we do not want any material coming up into the nasal pharynx or the nasal cavity, and we of course do not want any material down in the airway. All right, so now I'd like to show you a video fluoroscopy of a little child getting her swallow study done. So I'm going to play it through first, and then I'm going to go frame by frame so that you can see some of the key structures. Again, this is the nipple in the infant's mouth. This is that child's chin. Here you can see this area. This is the vallecula, so really pay a lot of attention to this area here. Swallow, swallow, and swallow. All right, I'm going to go frame by frame for you now so that you can see. We have a liquid in the child's mouth. It's going to slowly start moving over the base of the tongue. Here we go. Over the base of the tongue, into the vallecula, which is right here, over the epiglottis, and now it's going to start going into the esophagus. All right, I'm going to show you another one. Again, the material is in the infant's mouth. It's going over the base of the tongue, into the vallecula right here, over the epiglottis, and down into the esophagus. What's really nice to note about this particular infant is that they are sucking in a mature sucking pattern. They are doing sucking, swallowing, and breathing. And you can see that as the material here is about to go through the esophagus. Once that material clears, you're going to start noticing a darker black pocket open in the nasal pharynx. You see this opening right here? And then you could also see a pocket opening here in the trachea. There we go. All right, so this is the open nasal pharynx, and this is the open trachea. It's now an air-filled cavity. So this child was able to suck, swallow, and now is breathing. All right, so I'm going to play the next one so you can see how that looks. Breathe, swallow, and breathe. I'll play it from the top. Swallow, breathe, swallow, breathe, swallow, and breathe. All right? So that's good. That's what we like to see. What we don't like to see, I'm going to now show you a video fluoroscopy of a little girl who has penetration. So the material is entering the laryngeal vestibule, this area here, okay? When material enters this area, we call it penetration. When material goes then down into the trachea or down into the lungs, we call that then aspiration. So again, I'm going to show you this area here, what that looks like. And as you will note, this little girl has a trach in place. All right. Okay, so in this video, there were 5 swallows in total, and 4 of them she penetrated on. So I'm going to call that out now. Again, this is the nipple, this is the chin, the child's nose, her ear, and then her throat. All right, so it's there. Again, it's that finger-like projection. That's the second one. That's the 3rd penetration. This one is okay, and then the 5th swallow has that little line. So it's that finger-like projection. It looks like a finger-like projection because it's underneath the epiglottis, but above the vocal folds. What I could show you is at number, oh, excuse me, I'm at the wrong one. If we come to number 131. Okay, so here you can see this first pocket here. This is the vallecula. The pocket that's facing to your right, that's the epiglottis. This black is facing this way is the epiglottis. And then this area, this finger-like projection going to the left, that is penetration of the material down to the vocal folds in the airway, which we do not like. All right, taking a close-up look at this, you can see again, it's underneath the epiglottis, above the vocal folds. And this area is so important for our talk tonight because this area is very dense with special sensory receptors. These sensory receptors are called laryngeal chemoreceptors. And these are the receptors that are responsible for a lot of our A's, B's, and D's. If you want more information regarding laryngeal chemoreceptors, Reeks, St. Hilaire, and Proud in 2009 put out a really wonderful article explaining a lot of these sensory receptors and their responsibilities in the developing child. So, as well as in some animal studies they noted. So it was very well done. Again, these chemoreceptors, they may include irritant receptors, water receptors, C fiber endings, but you will note here is that they are most dense on the undersurface of the epiglottis, above the vocal folds. Again, this area we call the laryngeal vestibule, as well as here in the piriform sinus and alongside the arytenoid cartilage. All right, these receptors are dense primarily in this area because they are there to protect the airway. And what happens when liquid comes and stimulates these receptors, they elicit protective reflexes, which are collectively termed laryngeal chemoreflexes. Now, in children and adults, they would elicit something as simple as a cough or a swallow or an arousal. But in newborns and our preterm infants, we see exaggerated vagal and sympathetic responses, such as apneas, bradycardias, and laryngospasms, all or any of which can cause our DSACs, as well as some sympathetic responses such as systemic hypertension or blood flow redistribution. All right, so now I hope you're all looking around and saying, wow, that seems like a really exaggerated response for such a little baby. And you're absolutely right. These reflexes, these laryngeal chemoreflexes, they were not made to protect the newborn with these exaggerated responses. What they were actually made for was to protect the fetus. And the fetus, these same receptors and these same reflexes are then turned and called fetal protective reflexes. And their main responsibility was protecting those developing lungs from inhaling or aspirating any of the amniotic fluid. So as we all know, debris in your lungs is not good for no matter how old you are. But specifically for the developing lungs, we want to make sure that the only fluid in there is that fetal lung fluid that's produced by the epithelium. And what we know about the amniotic fluid that surrounds and bathes our fetus is that it is full of debris. There are skin cells, there's lanuga, that little hair that we find on the babies, there's vernix, that kind of cheesy material that we find on newborns. It is all just swimming around in the amniotic fluid. So these protective reflexes are there, again, to make sure that those developing lungs do not get any contact with the amniotic fluid, which can then obviously cause a lot of problems. And to make sure that the lungs are separated from the amniotic fluid, it now produces these reflexes. So in the fetus, it pretty much puts a halt to breathing. All right, and it's allowed to do that because all of the oxygen exchange is coming through the umbilical cord. So the three things that happen is that the vocal folds clench closed, which we call laryngospasm. The practice breathing movements of the lungs halt, which would be our apneas, and then the heart rate slows as well, which would be our brady. And they do that again, all for the reason of making sure that no amniotic fluid goes into or enters the developing lungs. All right, so what that looks like, again, we have these vagal responses. We have the apneas, the bradycardias, and the laryngospasms that result in the O2 desaturations once these infants are born. These reflexes, again, are there to protect the fetus, but when babies are born early, they stay, and this is what we have as a resulting factor of that. All right. So a little neurology. I know everyone's looking at their screen now and saying, oh my gosh, neurology. But we're going to go through it fairly quickly. What is important to note again is that one of three things can happen. All right, we could have our apneas, we could have our laryngeal closure or our laryngospasm, as well as the bradycardias. And what this looks like is, first, we have liquid that stimulates those laryngeal chemoreceptors, either in that laryngeal vestibule or close to it. And the laryngeal chemoreceptors send a message up the superior laryngeal nerve to the nucleus tractus solitarius in the brainstem. That afferent signal is conveyed to the motor neurons of the recurring laryngeal nerve in the nucleus ambiguus, which activates glottal constriction by contracting thyroid or arytenoids or the vocal folds into an adduction position. All right, again, that's called our laryngospasm. So that's the first or one of the issues that that infant can have. The second thing we see sometimes, again, material stimulates those laryngeal chemoreceptors. The message is sent up the superior laryngeal nerve to the nucleus tractus solitarius. It's interpreted in the brainstem, and then the afferent signal is sent to the phrenic motor neurons in the cervical spinal cord. And again, this inhibits diaphragmatic constrictions, which leads to our apneas. And then the third thing that can happen, again, we see material stimulating the laryngeal chemoreceptors, and the message is sent to the preganglionic cardiac vagal cells in the nucleus ambiguus, and that's sent up by the superior laryngeal nerve. And the efferent signals are sent to the heart, which decrease the heart rate, resulting in our bradycardias. So as you can see, it's involved, but it's happening, and as we can all see. I'm going to show you now a video of a baby. She was born at 31 weeks, and she had very, very frequent respiratory events during feeds. I'm going to show you now. I'm going to take the volume off because it's quite noisy in the background, but I just want you to take a look at her facial expressions as she's taking this bottle, and she is going to be having a Brady, so just keep an eye out for that. All right, so she's not breathing. She's looking very, very solemn. Some signs of distress. It's hard to see, but her color is getting slightly dusky. And now she's eliciting her cough. Okay, it is about now in the videos that the monitors are going off. It's just interesting to note and very important to note that we always want to pay attention to the infant's face, her coloring, their cues, instead of having our eyes glued up on the monitor. Had I not been looking at her face and realizing that she had stopped sucking and stopped breathing, and didn't notice that her eyes kind of froze up, I probably would not have caught that as quickly because, like I said, the monitors picked this up much later, much after I started to already intervene. Okay, and so what this probed was for us to say, all right, enough is enough. We've tried different kind of strategies. I don't know if you can see, but she was being fed in the side-lying position. We were doing pacing. Again, if you didn't notice, I had pulled the nipple out of her mouth. I didn't wait for her to have a Brady with the nipple in her mouth. I was noticing some signs of distress, and I pulled the nipple out of her mouth. So that's a pacing technique. So after all of these things weren't working, we were using a special nipple, we were doing pacing, we were doing side lying, and still her feedings were eliciting these A's, B's, or D's. So what we decided to do was a swallow study, and I'm going to show you now the what that looks like. So we have our swallow study. Okay, so you can see that she has a lot of residue within her pharynx. This is her pharynx area. This is the vallecula you see. As she swallows, we have some material coming up into her nasal passage. And then now we see material pretty much go everywhere. I'm going to freeze it on a frame so that you can see that widespread difficulty that she just had with that swallow. Okay. Okay, here you can see liquid on the back of her tongue, on the base of her tongue, here in her vallecula. This triangle here, this is her epiglottis. You can see there's material underneath the epiglottis within her laryngeal vestibule. And then down here, this is material in her trachea. All right, this is actually a better picture. So this is the vallecula. Here is material in her laryngeal vestibule, and here is material which is aspirated in her trachea. All right, so again, she was having a lot of widespread difficulty. Again, the nasal pharyngeal reflux, this is material that came up and entered her nasal passage. There was material that kept coming into her laryngeal vestibule, which was very dense with those sensory receptors, as well as material that went down into her airway. All right, so not only can the laryngeal chemoreceptors be triggered by swallowing acts going into the airway or that laryngeal vestibule, but it could also be triggered by reflux coming up from the stomach and the esophagus. All right, now obviously there's a lot of different terms for reflux. It could be the gastroesophageal reflux, GI reflux, there's a million different terms, but pretty much both acid and non-acid gastric contents has been identified in the triggering of the laryngeal chemoreceptors. It's sometimes that unexpectedness of reflux that can come up and trigger those, but it is also very commonly seen as a secondary factor to having a poor swallowing mechanism. All right, so if a child that you are seeing has repeated Brady's or A's, B's, and D's after the feeding and you're suspecting reflux, we also want to possibly consider the fact that there might be a swallowing issue as well. Remember, swallowing is a sensory motor act. When material comes into contact with the receptors responsible for swallowing, immediately it should be able to trigger a swallow to protect the airway. So what we're finding is that if it's not happening during the swallow, when material is coming down from the mouth, it could also be having that same deficit when material is coming up from the stomach. So it's something to keep in mind if we're seeing repeated A's, B's, and D's after the feedings due to suspected reflux. And again, the presence of acute or chronic laryngeal inflammation may also heighten these laryngeal receptor activity. So that's all something to think about if we're having a lot of issues of reflux, that acid could be coming and causing some inflammation, which makes the elicitation of these receptors more severe. Okay, and what I'm going to show you now is a video of an infant which has nasal pharyngeal reflux. This is material that goes up until the nasal passage during the swallow. Okay, so you can see there's already some material up, and it's videoed in fast time, but you can see how frequently material keeps going up into the nasal passage. All right, again, this is not preferred. What we find is that some infants do not adequately clear the material that's up in their nasal passage, and that material will randomly drop at a later point after the feeding. So sometimes when we talk about material coming up from the stomach and causing reflux to trigger these laryngeal chemoreceptors, it could also be material that has stuck in the nasal passage that drops at a random time and triggers them as well. So again, we have three main routes for these receptors to be triggered: from the swallow during the swallowing acts, as well as after the feeding from possible reflux, and from nasal pharyngeal reflux. Okay. So the great question is, now what? Now that we know that these children are having these difficulties, what are we going to do? Well, we're going to intervene. We're going to call up our feeding and swallowing specialist in the NICU, and they're going to come to do a bedside feeding evaluation. This is a subjective assessment, but there is a lot of feeding modifications that we can do at bedside and be able to see immediate improvements based off of the cues the infant is giving us. And I can't stress that enough. We want to be communicating with our little ones based off of the cues that they're giving us. So things that we may do, we may alter the nipple flow rate, which alters the bolus size they are swallowing. We may try different positions. We may try a cue-based feeding, such as using something called pacing or regulation. If and only if those fail to help the infant be successful with the bottle, we will then order an objective feeding evaluation. And the gold standard is really the modified barium swallow study, which is also termed a video fluoroscopic swallow study, depending on your hospital system. And again, we study only and only after trying different positions, different pacing techniques, different bottles, and of course with continued maturation of that infant's feeding development. I do not want to study a child who is only a couple of days old or who hasn't reached sufficient gestational age, closer to like 36, 37 weeks gestational age. And these practices are also well supported in the literature. And like I said, only with no improvements or continued suspicion of aspiration is when we will then consider a swallow study, and only after that. All right, so one of the interventions that we are probably the easiest one to do is altering the nipple flow rate, which thereby helps the bolus size. And there's a lot of research out there here now really indicating that it increases, a higher flow increases the chances of apneas and bradycardias, because the size of the swallow is too difficult for that infant to control. That apneas increase as bolus size increases, and again, the large volume swallows were more likely to incline inspire post-swallow breath. What we want to do suck, swallow, expire, so that any material left in the airway will come out. But because there's such as incoordination and they have such a hard time controlling large volume in their pharynx, we find that they very often do suck, swallow, inspire, which could be bringing some of that leftover material into their airway. Some of the nipples that are available in NICUs, we have slow flow nipples by both Similac and Enfamil. We have regular flow nipples. Even though the blue cup here is advertised as a standard flow, if you tested it, you'll actually find the blue cup to be much faster. There are also in some NICUs still the Nook as well as the premature nipple. I will tell you, if you want to drown a baby, use this red nipple. It is the fastest flowing nipple that I've seen in a long time. And it come from previous understanding, which is now a major misconception, that preterm infants don't have a good suck. So therefore, you have to provide them with a faster flow. And that has been repeatedly negated in the recent research. So what we know for sure is that we do not want the faster flowing nipples. We would definitely prefer our infants to be on these slow flow nipples if they're having difficulty. And again, because every child is going to respond differently, we do like to have a little bit of a variation. We want to treat very, very individually. But like I said, for a lot of our children who are having feeding difficulties, these slow flow nipples absolutely do help. And again, the reason for this is that the higher flow rate makes coordination of sucking, swallowing, and breathing more of a challenge. And because respiration, feeding ability, and swallowing safety are also highly affected by flow rate, we want to make sure we're having a lot of options for them to accommodate their skill set. Okay. Also, because of the knowledge that now preterm babies respond better to slow flow nipples, Dr. Brown's has done a really great job filling in the gap of the needs of some of these babies. There was a great study done by Kelly Jackman just last year that measured the flow rate of various nipples available to preterm infants. So the standard ones, the Similac slow flow and the Enfamil slow flow, they're generally slow, as well as the Dr. Brown's premature nipple. They were found to be slow, but again, because we know that they respond better to even slower flow, they then came out with their ultra preemie nipple just half a year ago. And it is advertised to be 35% slower than their original premature nipple. So although this nipple wasn't done in Kelly Jackman's study, if you do the math, it would be flowing somewhere around 5.2 milliliters a minute. And I've had the pleasure of already using this nipple on some of my preemies in our NICU, and we are seeing a lot of success with them. So I'm happy to have them, and I'm happy to help educate others on their use, because it's been a very big life send for some of them. And we actually use these nipples in our video fluoroscopies. When we do a swallow study, we not only look for a dysfunction, but then we're trying to fix the dysfunction. And one of the first things we do is try a slower flow nipple. So it's nice that we have all of these options. Another intervention that we do very often is the side lying position. What we find, it helps with better oxygen saturations, decreases the work of breathing, and less heart rate variability. So what this means, if you were holding a baby in your hand, or in your arm rather, the baby's nose would be up at the 12 o'clock position on the clock, all right? So what we want to do to achieve a side lying position is we want to turn the child on its side with the head, shoulder girdle, spine, sternum, everything to still be in perfect alignment, but with the nose facing the 3 o'clock mark on the clock. Okay, so we're literally just going to take the baby and shift them a quarter degrees clockwise if you're a righty, or counterclockwise if you're a lefty. Right? Why this is so great is because it affords more ease of the anterior posterior rib cage movement during breathing, thereby making breathing easier. It increases lung compliance. It makes it easier for the head and trunk alignment to stay stable. And of course, our gold standard, always, 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 it is most similar to the cross cradle position that we see in breastfeeding. Again, that is our benchmark for optimal oral feeding experiences. So we like the side lying position. Also, if you were holding a nipple, a bottle filled with milk, hold it straight up and down or in that regular upright position, there's something called hydrostatic pressure. So all of the liquid in that bottle will be pushing down. There'll be pressure on the hole, making it a faster flow nipple. But again, if you hold that bottle and that infant on the side, you actually reduce the hydrostatic pressure by half, making it a slower flow nipple and more control to the baby, which is always our goal, is to give the babies more control. And here are some pictures of infants in a side lying position. As you can see, their noses, their whole bodies are in alignment, but off to the side with their nose facing a 3 o'clock position. And in this picture here, you can see that hydrostatic pressure is reduced by half. Okay. All right, in Cubase feeding, this should be its own talk all in itself. Cubase feeding, there's some really great researchers out there. There's Catherine Shaker, there's Suzanne Thoyer. There's a really big push now to get out of a volume-driven culture and into an infant-driven culture. I don't want to spend too much time here because, like I said, I can go on a complete rant. I think this is the most amazing new set of literature, most pertinent to our little ones that we've seen in a while. And what this pretty much allows us to do is to really communicate with our little ones during a feeding, to look at their facial cues, to offer them pauses based on their signs of stress, and to help them do what they are telling us they can do from a physiologic stability standpoint. We want to go by what they can do on that particular day, on that particular feeding, based off of what they're telling us. All right. So again, going back to this little baby, she was able, just by her cues, to let me know what she needed. All right, I saw that there was a little bit of stress. I pulled the bottle out, and sure enough, she was having a lot of stress. She was having a bradycardia. All right, her swallow study then showed all of these difficulties. She had penetration. She had nasal pharyngeal reflux. She had aspiration. So in our unit, we developed a feeding protocol to let all of the nursing as well as all the caregivers know what our plan is for her. So due to the findings of the swallow study, I did try numerous different modifications. I tried slower flow nipples. I tried a different position. I tried some pacing. Nothing was able to help with her dysphagia, with her swallowing difficulties. So we do the last intervention that we can test under video fluoroscopy is thickening. And sure enough, that helped her significantly. We used Nectar Thick, which then she still aspirated on. So then we had to go down to Honey Thick, and she did much nicer for that. Because we went to a honey thickness, we use a special nipple so that it accommodates that thicker liquid. We can't just put a new thickened liquid in a regular flow nipple because they will not be able to suck the material out without burning way too many calories. So we started using the Dr. Brown's nipples in our unit to help accommodate the faster flow rates. And I'm going to show you which recipes and nipples we use in a moment. We also found that the very, very upright position worked best for her, and that helped reduce some of the nasal pharyngeal reflux that we were seeing. We also used pacing. Again, we paused when the infant showed stress. We were going by her facial cues. And we wanted to limit all feedings to under 30 minutes, which is true for all of our little ones. All right. Again, always keep in mind, and I cannot stress it enough, thickening is never our first intervention. Our preferred intervention is identifying feeding modifications to improve swallowing in preemies with dysphagia. Because it's another hot topic in the field right now, but thickening for dysphagia is problematic for many, many reasons. In our unit, this is the recipes that we are using. We do utilize a half nectar. We do this sometimes to just provide the least restrictive environment for our little kids. And what we find under fluoroscopy, if they do respond better to a slow flow nipple, we can make that as individualized for them as we can. So if they are on a nectar, we use 1 tablespoon of rice cereal to 2 ounces of formula. And we'll use either a level 3 nipple or a level 2 nipple. And same for honey. Again, we have a slow and a regular variation for them. And again, to tell you, the Ycut nipple, we do not like to use it ever, ever, ever. It makes a very, very large bolus. So even though it looks like it would be slow, like it would give that child an ability to control what goes into their mouth, and when they do decide to suck, too much of it goes into their mouth. And we never want to cut a standard nipple. I know this was very basic pattern for us for a long time, but now because there are so many different nipple variation flows that we can choose, we really don't want to do that. It makes the bolus too unpredictable. All right, thickening liquids, again, we use it because it improves the effectiveness and safety of the swallow, thereby reducing the risk of penetration or aspiration. It helps improve the child's oral control of the liquid and coordination of suck, swallow, and breathe. After discharge, we want to make sure that they continue on that recommendation for thickening until another swallow study is done to objectively assess that child's safety. What we find is that about 80% of our little ones outgrow their dysphagia in 6 months. Because again, a lot of this is maturational. They really do nicely in about 6 months. And as pediatricians, I want you all to talk to the parents and make your own record of their interpretation of the frequencies of A's, B's, and D's in the NICU, because sometimes the discharge papers from the NICU don't really specify how frequently they were having A's, B's, and D's. Were they during the feeding or after the feeding? So go ahead and ask those parents these questions. Takeaway points for you is that A's, B's, and D's are linked to these laryngeal chemoreflexes. They are stimulated by swallowing difficulties and or reflux and or, again, that material coming up into the nasal passage. They feeding modifications really can be used successfully to eliminate these occurrences, and they should be taught to all the nursing staff and the parents. And when the modifications don't work, then and only then do we consider the swallow study. And any recommendations regarding thickening should be continued until a repeat swallow study is performed. And so thank you so much for listening in. And I think I'm going to open up the floor now for any questions.
If a baby is nippling expressed breast milk and aspiration has been documented during the MBS, is that baby taken off breast milk to accommodate the rice cereal, provided all other strategies do not work?
So this is a major conversation. I actually gave a talk about it last night. It's a problem. It's a problem because the amylase enzymes in the breast milk so readily break down the rice cereal in breast milk. So, I'm sorry, in breast milk breaks down the thickening agents of rice cereal. So what we find is we have 2 main options. What we try to do is educate the parents, and we as a group come up with the decision. So one of the options that we can do is to ask the parents to continue pumping, but while they're stay in the NICU to let us thicken formula only and feed formula only. And then upon discharge, the infant can then continue on breast milk with a product called Simply Thick. Simply Thick is a locust bean gum. I'm sorry, not Simply Thick. Oh, forgive me. simply like is no longer approved for infants. I'm sorry, the product that I like to recommend after discharge is called Gel Mix, and it's a locust bean gum thickener, and it was formulated specifically for infants. The two prerequisites for Gel Mix is that the infant has to be over 6 pounds and over 42 weeks postmenstrual age. So we find that some of these infants then meet those requirements at discharge or shortly after discharge. So again, they are only fed formula thickened with rice cereal in the NICU, and then at discharge can continue on the pumped breast milk with the gel mix. So that's option one. Option two is that we will go ahead and thicken the breast milk, but we have very strict mixing and remixing instructions. So for example, I would have the parent or the caregiver or the nurse swaddle the baby, sit the baby down, have the baby already in the arm, and then right in front of them at a table, mix the rice cereal into the breast milk, shake, 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 and feed it right away, all right? Because every minute that passes, the amylase is breaking down that thickening more and more. And then after 4 minutes, the parents or caregivers are instructed to check the thickness of the liquid. So what they do is they take a clean paper towel, they turn the bottle upside down, and they shake it up and down. 1, 2, 3. We would expect to see between 5 and 10 droplets come out onto that paper. If more than 10 droplets come out, they are then instructed to add 1 more teaspoon of rice cereal to the breast milk. Shake, 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 and feed the baby. And they have to do that every 4 minutes. So it's quite time consuming, but because we're now putting the thicker liquids in the bottle, we're using the faster flow nipples. But if the liquid starts thinning and coming out of a fast flow nipple, we're really putting that child at risk. So we educate the parents that this may allow the child to continue to aspirate, and that that child may have a little bit of a longer stay, a hospital stay, because unfortunately, you know, it takes one caregiver to lose track of time, or to be answering a question, or to be silencing the baby's alarm and not realizing that maybe that liquid is getting too thin. So again, as a team, we come up with that decision. We go very individually, family by family. Some families are fine. They're like, oh, you know what, let's just give them the formula, let's get the baby home. And then there's some families who feel very strongly they don't want their baby on any formula. They want breast milk only, and so we try it. So we try to be as individualized as we can. Any other questions?
I think that we do have several more questions that have been entered since the end of the presentation, Louisa. I'm sorry, we're just about out of time, so we no longer have time to answer these questions. What we're going to do, though, is we're going to we've copied these questions. We will present them to Louisa, ask her for her expert information, and let her complete them, and then we will send them to everyone who has attended the webinar.
Wonderful.
So I want to thank Louisa very much for her presentation. It was very interesting and very educational. We appreciate your time and your information. I want to thank everyone for joining us today. As we mentioned at the beginning, we'll be sending everyone a link to the recording of this webinar. You have Louisa's information here on the screen if you'd like to contact her directly. If you'd like more information about this webinar or future Dr. Brown's educational series of webinars, please make sure to contact us through our website, drbrownsbaby.com/medical. And thanks again. This concludes today's webinar. Please have a great day.